I'm just going to go over a few logistics before we get started. So we are in webinar format. So all of the participants are muted. We ask that you send your questions in through the Q&A function, and we'll do the best to get those answered throughout the webinar. Anything we can't get to, we can follow up with, and we'll share out any of the Q&A text file and any resources that come through that. Everyone that has registered will get a follow-up email, usually in about 24 or 36 hours, with both the recording link and any resources talked about today, including the paper and any other great pieces or news pieces, whatever comes out of today. We'll kind of aggregate all of that and share it out with everyone. Quickly, I want to thank our funding partners of the Think Bigger, Do Good policy series. We couldn't do it without this lovely group of both funders, but also thought partners that really have made the policy series what it has been over the last 8 or 9 years. And then I want to acknowledge our dissemination partner. We have worked with Lisa Dixon and Psychiatric Services to co-publish all of the Think Bigger, Do Good policy papers, and appreciate having another outlet to share these works. So with that, I'm going to hand it over to Jane and we will get started.
Great. Thanks, Ellie, and thanks to everyone who is joining us today. I am really excited to be moderating this discussion with the four authors of the Think Bigger, Do Good policy paper, Building the Behavioral Health Crisis Response Workforce. This is a very experienced and talented group, and as you will learn, they bring different perspectives to the work. This paper comes at an important moment. Over the past several years, we've seen significant growth in behavioral health crisis response systems across the country, including mobile crisis teams, crisis stabilization services, and 988. But at the same time, many communities, like my hometown of Buffalo, are running into the same challenge. There are just not enough trained professionals, peers, and responders to meet the growing demand. So today's conversation will focus on that question. How do we build, train, and sustain the workforce needed for a modern behavioral health crisis response system? To get us started, I'm going to ask each of our panelists to introduce themselves and perhaps highlight something from their professional or personal experiences that influences how they approach the topic. Ellie did share their bios to start, and I think she may be able to put them into the chat for those that missed it. But I'm going to start with Amy. Could you go first?
Sure, thank you, Jane. So I'm Amy Watson. I'm a professor at Wayne State University in Detroit. I started my career as a probation officer on a mental health specialty team and did that for about 7 years. And that really, I learned a lot about how the mental health system and the criminal legal system don't work for people. I went back to school, got training as a social worker and a mental health services researcher, and been bringing that training and perspective to my work. I also identify as someone with lived experience, both personal and as a family member, and that informs the work that I do too. And I'm very fortunate to work with a team of folks that are really smart and bring different perspectives to the work.
Leah, do you want to go next?
Great, thanks. Hi, everyone. Leah Pope. Glad to be here with you all today. Something sort of that jumps out to me immediately. I'm an anthropologist, and so a lot of my early training has been in long-term ethnographic fieldwork with communities that are system involved in multiple different systems, child welfare, criminal justice, mental health systems. And I would say that a lot of that work has inspired my work today in terms of talking with individuals, young people and their family members about what they need in moments of crisis, what would be helpful and what is not helpful. And so much of our work really, as sort of echoing what Amy said, is motivated by direct experience talking to people who have experience with these systems.
Thanks, Leah. Kellan, how about you?
Sure, thanks, Jane. Hi, everybody. My name is Kellan McNally. I'm a doctoral candidate here at Wayne State University in Detroit in the social work and anthropology Ph.D. And I've been working for the last 4 years now with Amy, Leah, and Michael. Had the privilege of working with them. I came into the doctoral program with about 10 years of clinical work in emergency mental health services, mostly out of Massachusetts, where I previously had my clinical license, now working out of Michigan, doing some clinical work here in Michigan too. But yeah, I would say that my years of working for a mobile crisis service definitely informs my perspective and my thinking about mental health services and sort of sitting with families and individuals in crisis.
Thanks, Kellan. And Michael, finish us off here.
Okay, thank you, Jane, and thank you, Allie. After I finished my 4-year psychiatry residency in Atlanta at Emory University and at Grady Health System, I then completed a 2-year fellowship in community psychiatry. Now, this was 25 years ago, and I had a lot of hair. During that time, though, I worked in a mental health court. I worked in a substance abuse treatment program. I helped Georgia develop its CIT program. And I spent 4 months riding on a mobile crisis team. And that experience and spending so many hours sitting in clients' living rooms, assessing and assisting in crisis situations really made a deep impression on me. I'm glad to now be doing research on crisis response that both involves law enforcement like CIT and co-response, and also that does not involve law enforcement like mobile crisis teams and alternative response programs. So thank you for having us.
Yeah, I've actually had the chance to talk to all of you, and I still learned something new from those introductions. So thanks for sharing what your experiences are. Before we get started with our formal part of the session, we are going to start with a poll question. Ellie, if you can put that up. So what is the biggest barrier to expanding crisis response capacity in your community? You can choose between workforce shortages, funding limitations, coordination across systems, policy barriers, or maybe it's something we don't even have listed there. I can't see if we're getting any responses in.
We are getting a few. Let me see if
I think we should have had all of the above, maybe as a possible choice, just speaking for Buffalo and what we've encountered here.
All right, so we have about 41% of participants have responded, and this is not going to be a surprise to anyone. Workforce shortage, funding limitations, and coordination across systems are really tied pretty closely, with about a third or a little bit less. And then there's a few others coming in. I think workforce shortage is just pulled ahead.
Edging it out, yeah. Well, exactly right. None of those would be a surprise. And any one of them could be the leader or it could be a complete tie across. And so, Amy, I'm sure you're used to seeing responses like that come in when this question comes up. Oh, I just got to win. So workforce shortages for the lead for 44%. So Amy, it would be great if you could sort of help us all get on the same page. I know people are coming in with different experience with this topic. You could just be a concerned community member who wants to learn more. So if you could take a few minutes and provide us some background on the crisis response system, and then share a bit about what you cover in the paper. Oh, Amy, you're still muted. Sorry.
Told
Thanks.
myself I wasn't going to do that. So there's been a lot of effort to expand crisis response services. I think 2020 was kind of a pivotal moment with the confluence of the COVID-19 pandemic as well as the murder of George Floyd. There's been a lot of attention on the need to get a mental health response to mental health crisis and also to reduce contact with law enforcement for things that don't require law enforcement. And these two streams have really kind of moved forward along, well, this has moved forward along two streams that kind of overlap a bit. The first one would be the expansion of mobile crisis response teams. And these typically exist within the behavioral health system. There's been a lot of federal government support for the expansion, or in some cases, the initial development. Certainly, the federal government supported increasing the Substance Abuse and Mental Health Services Administration block grant, mental health block grant, and they've created the requirement for states to allocate at least 5% of their block grant to crisis services. We also saw with the American Rescue Plan Act of 2021 that introduced an enhanced 85% Medicaid match for mobile crisis services meeting specific criteria. The 2022 Bipartisan Safer Communities Act authorized expansion of certified community behavioral health clinics, that Medicaid demonstration, and that requires CCBHCs to provide or contract for mobile crisis services. 20 states and DC have received approval from the Centers for Medicare and Medicaid Services to use that 85% Medicaid match authorized by ARPA. We've also seen 12 states enact 988 surcharges to support crisis services. And 2 states, Illinois and Virginia, have passed legislation that requires the transfer of some behavioral health related 911 calls to 988 and to mobile crisis teams if an in-person response is needed. So NRI, or the National Research Institute, which is the research arm of the National Association of State Program Directors, State Mental Health Program Directors, collects data annually from program directors in each state, and they do a series of state profiles. And in their recent state profiles indicate that in 2024, states reported a total of 2,448 mobile crisis teams, and that represents a 32% increase compared to 2022. So we've seen this rapid expansion in standing up additional teams. These teams are typically supported by state general funds, Medicaid, and mental health block grant funds. Some are billing private insurance. You see city and county government funds as well. And in 2024, one state reported using their 988 telecom surcharge to fund mobile crisis teams. The second pathway is occurring at the local level within the public safety system. And here we're seeing a growing number of cities that, in an effort to really shift things that don't need police away from police, they're implementing unarmed alternative response teams. And they respond, oftentimes will respond directly to 911 calls, to behavioral health crisis calls. They may also go to an expanded list of calls that simply don't require police. So it could be other types of issues related to folks that are maybe unhoused, other types of situations that don't have a significant criminal component that requiring a law enforcement officer. And we don't know the exact number of these programs. It's kind of a moving target, but the Policing Project estimates there's about 130 of these programs across the U.S. And funding for these teams typically will come from local tax levies, municipal and public safety budgets, and state and federal grants. A few of these teams also bill Medicaid for some of the services that they provide, and some of these teams also use ARPA and opioid settlement funds to fund them. Slide. So all of this expansion requires people. And going back to some of the NRI state profiles, in their survey, 90% of state mental health directors reported that they have behavioral health workforce shortages. And specific to mobile crisis teams, states report the greatest shortages in social workers and other licensed clinicians and peer support specialists. And we also know that some of the hiring requirements for these types of teams may not actually reflect all of the skills that people need, particularly when you're talking about responding to calls that come in through 911. I've been at a school of social work for several decades, and you can go through your graduate training and not actually get a lot of content on crisis intervention. And many of these graduate programs are really training people more focused on office-based therapeutic work. So those degrees may not be all that you need. It really kind of leaves it to agencies to kind of fill in that gap. We also know that the alternative and community responder teams will hire a broader range of people. They may have licensed clinicians. They may focus on hiring folks with different types of lived experience. They may have EMTs and paramedics, and then they typically will develop an in-house training academy, oftentimes around 6 weeks of initial basic training for their teams. But they have to kind of do that in-house. There's also not currently a recognized training standard for mobile crisis teams or alternative community response work, although SAMHSA recently released an advisory with a national standard, which is something that our team really worked hard on, and the work that we're talking about here really informed. So in terms of thinking about what are the biggest barriers to meeting this need, what I would really argue is that the biggest barriers that we don't recognize the skill set for this work as a distinct from general clinical skills. We so then we're kind of relying on traditional clinical training and licensure, which may not provide exactly what people need for this work. And then, of course, you have agencies that will have to fill in this gap. And certainly there are people with these credentials that develop excellent crisis response skills and really do want to do this type of work for the long term. There's just simply not enough of them. So we really need to think about using our licensed and credential folks a little bit differently and figuring out how we can develop a workforce underneath that. Because limiting eligibility based on these traditional credentials really excludes a larger group of people that may have a lot of interest in work that's in the community all the time, varied every day. And they may be very well suited to it, but they don't have the resources or the interest in pursuing advanced degrees to get into the field. But they certainly may have the ability to develop those skills. And once they do that, may also be more interested in staying in the field longer because that's the type of work they want to do. So at this point, we're throwing in bachelor's and master's level folks into these roles. And it's up to the agencies to provide their training. And agencies have different capacities to do that. And if people aren't adequately prepared for the work, they probably won't stay that long because nobody wants to be doing this really important, intense work and feeling like they're not competent to do it. So I think that may contribute too to retention issues. Slide. So we've been really fortunate to get some funding from NAMI National to really look at addressing this gap. And we've done work to develop the foundation for the community behavioral health crisis responder as a distinct professional role. And through this work, we were able to develop values, competencies, and skills designed specifically for the crisis response workforce. And really, this is kind of the foundation of work we're now doing with the Illinois Certification Board to develop the first community behavioral health crisis responder credential. And the idea will be that once it's established in Illinois, that it would be made available to other states in coordination with the International Certification and Reciprocity Consortium, ICNRC. And what we're really thinking is that then we would build into a training and credentialing process that's designed to support workforce entry for people that have that don't have academic degrees, but also for people that do. And I think about this a little bit like you have EMT paramedic progressions where people go in, they get really focused skill-based training, and they have some progression. We also see this with the certified alcohol and drug counselor credential, where you have people that may not have any post-secondary education, but they get the credential and they can work in the field. But you also have people with bachelor's and master's degrees that will get the credential as well to work specifically in the field. And really, our goal here is to remove barriers to entry for people that are well suited to the work and while still ensuring competency so that we have really quality crisis response. So that's kind of the foundation of what we're doing. And I know in the paper that we did, there's a lot of policy recommendations as well to move this forward.
So Amy, that 90% states feeling a shortage in this area. I mean, it's certainly a national issue. But one thing you said is sort of resonating with me. It's not just that the person coming into the field maybe isn't properly trained or, ready for what's being asked of them, but the toll that takes on the rest of the team that they're with, right? So onboarding a new team member and this time intensive skill set that they're helping them, and then to have that person leave, you're really asking a lot of those existing workers to carry the load. And I could see how that burnout could happen for them as well. And
Right.
seeing this sort of transition or sort of constant movement of coworkers and employees. So thanks. That was a great way to sort of set the table for us in our discussion. And you raise a really important point, right? Are we finding the right people and are we training them the right way? So Leah, if you could tell us a little bit more about that credential that Amy had just closed with and how that could impact this workforce pipeline.
Absolutely. So as Amy mentioned, this credential is really the foundational elements build on the values, competencies, and skills that we've outlined. And just to give a little bit more clarity on what we mean by that, we're talking about very basic values, but really central elements to what we see as the core of crisis work. These are values like dignity, respecting the dignity and inherent worth of every person, autonomy, supporting people that in ways that enhance their autonomy, and values like knowing about trauma-informed approaches and valuing lived experience. So we start with prioritizing how to communicate those values in any sort of credential and training. And then we've developed these competencies and skills that we really think are integral to the role, regardless of what team you end up working on. And those competencies and skills are divided into sort of 4 different categories, if you will. The first being relationship building competencies, things like self-awareness and collaboration. Communication competencies, such as active listening, how to do verbal and nonverbal forms of communication effectively, how to be culturally responsive in your communication. The second category is really knowledge-based competencies. So these are thinking about specific pieces of knowledge that you would need to have to be competent in your role. Those are things about mental and behavioral health, such as signs and symptoms of a disorder, physical health. You might need to know harm reduction skills, for example, motivational interviewing, other sort of the kind of specific knowledge skills. And then also we focus on safety related competencies and skills. So that's things like how to manage the physical environment or how to prepare adequately for safe interactions as a team member and how to de-escalate crises effectively. And then finally, the area is really just sort of an other area, additional areas of competency. And that would be things like knowing your local resources or having basic knowledge of the housing system in your community. So that's sort of the overview of what we think would be the sort of foundation of the credential. As Amy mentioned, we're working with ICB to develop and structure the actual credential. Our vision is that the prerequisite to sort of beginning this process would be either a high school diploma or a GED, so no college background necessary. And then the training would then last over a period of 6 weeks and would include both didactic hours where people are sort of in a more traditional classroom, as well as skills practice lab and importantly, practicum hours. The idea being that you could get provisional certification after this initial 6 weeks and passing a practical exam. And then you could apply for a full certification, full basic certification after supervised work experience. 1,000 hours is what we're sort of thinking. So that would be about another 6 months of work experience on the job. And we think that this really can fundamentally shift how we think about the pipeline, right? So you're starting with a much broader pool of candidates. You're starting with anyone with a high school diploma or a GED. You're removing traditional barriers to entry as a result of that. This credential would also be designed to prioritize people with firsthand experience of the systems we're talking about: behavioral health treatment, housing instability, incarceration. So those would not be barriers to starting the training or getting the credential, which is not always the case. And then finally, we really, support this idea of having intensive training in a consolidated period of time, but then continuing to build competency and capacity for people as they're working and being paid. And so really that commitment to career development in the role.
Yeah. And am I right, Leah? This could be like you just talked about career advancement, but like a stackable. So if someone's a certified peer, they could then go and get this credential and have that sort of additional.
Yes, exactly. We anticipate the goal would be for it to be stackable. So people might have this credential and a peer and a CASAC, for example. And I think I mentioned this, but just sort of really being committed to the idea that it would be ultimately transferable across a variety of types of teams, since we know there's so many models out in the field.
Yeah. Thanks. So we obviously can't rely on the traditional way we've been doing things, right? It's not producing the workforce we need, and certainly not at the scale that we need it. And you're talking about bringing in a whole new group of people, right? Expanding that net. So Kellan, can you tell us about what role a community college or a regional training program could play in helping sort of reach these people and prepare them for this work?
Absolutely. I'll try to cover the community college question. So first of all, I'd say that each educational setting comes with its own set of benefits and limitations, including graduate training programs like the one that I went through. But I think we know that expecting aspiring crisis responders to get master's degrees and then licenses in order to become employed in the crisis care system is just going to become a setup for worsening the same shortages we're already seeing. So I think community colleges definitely can play a role in expanding access to this wider group of people so they can enter these positions, given the longstanding associations for community colleges between associations with lower cost, fewer years of schooling, and more flexible scheduling. These historical ties between community colleges and workforce development, including these close ties that they often have with employers right in their communities, positions them to offer multiple pathways. We've talked a little bit about this. This could be students who are pursuing associate's degrees without any prior higher education, or other students who have perhaps completed training already but want to return to get more specialization in crisis response that was maybe missing from their previous training. So I think both these ties with community colleges and local employers positions these programs to offer the kind of supervised placement in the field that students would need, as well as maybe to develop paid apprenticeships that could connect work-based learning to actual paying jobs in the field of crisis response. I was going to say one more thing, which is that we ought to acknowledge and recognize that the high cost of university training, especially when it requires unpaid practicum, it's just going to continue to exclude many students who could be interested in this work. Organizing workforce around that model of unpaid practicum, it really risks reproducing in the crisis response workforce. It risks reproducing a crisis response workforce that has too little in common. It has very little in common with the people in the neighborhoods that it's serving. So I think what we're talking about is really trying to develop something that will attract students that share some sense of membership and really broadly defining membership with the individuals in the communities where they will work, because maybe those individuals have been on the receiving end of services and have some firsthand experience that they can apply to helping people navigate those systems, or maybe even navigating their way out of those systems and away from those systems. So therefore, we want to recognize community colleges, how they're positioned to provide that kind of education that can reverse this exclusion that a lot of university-based professional degrees are currently seeing. We can do this by creating lower burden routes into the field that are connected to paid employment. We've seen a small, maybe growing, putting some qualification there, but a small number of behavioral health apprenticeship programs across the country, some in California, New Hampshire, and Ohio, where these programs are aligned with state certification requirements for different types of behavioral health roles. And I think really what's missing is an understanding about the successes and the challenges of these programs. And we could be learning from these kinds of earn while you learn models and thinking about how apprenticeship could be applied to crisis response careers, particularly to attract people who are, for whatever reason, not good candidates for four-year university degrees, but who would like to do this work and who, as Amy has said, are well suited for it.
Yeah. So I'm super excited about that because we do a lot of partnerships with community colleges. So I'm already thinking of how to work with them a little differently. And admittedly, we work with them mostly on STEM degrees, but not mental health. So this is one I just took a note of the 3 states that are doing
Cool.
it, Kellan. So thanks for that. Did someone want to talk about the regional training centers? Amy, I don't know if you are able to do that.
Sure. I mean, I think there's some opportunities here to develop some regional training centers that could provide some support to community colleges that may be implementing curricula and really kind of working through that and being a regional resource. And we have some examples of this. Certainly, SAMHSA has funded technical assistance centers that include some training components. Some states also have behavioral health workforce centers that could serve as sort of a central support to community colleges or other organizations that may be standing up some of these training programs.
I think we can all agree that these are wonderful solutions, but they depend a lot on policy. What can be reimbursed, who is recognized as part of the workforce. It sounds like there's some progress being made on that, but we're a long way to go. So Michael, I'm going to turn to you. For policymakers and philanthropic leaders in the audience, what specific policy changes or investments would most accelerate this workforce development?
Thank you, Jane. Like any other issue that's related to access to healthcare or social justice more broadly, you're exactly right that the solutions depend on policy. And there are many levels of policy at play here with regard to the crisis workforce at the institutional level, the local jurisdiction level, the state level, the federal government level. I'm just going to make a few comments at the state level. First of all, we all are aware that Medicaid remains the predominant funder of mental health services in our country, notwithstanding the looming cuts enacted by H.R. 1. At the state level, state mental health agencies and state Medicaid agencies, I think, should really work together to optimize all Medicaid opportunities, like the types of services covered, the billing codes, the provider types, service requirements across the full spectrum of crisis services, including mobile crisis teams, crisis receiving and stabilization facilities, crisis respite, crisis residential services, and even crisis transportation. This will likely require submitting Medicaid state plan amendments specifically targeting crisis services, and many states have done that over the past decade. At the state level, though, aside from Medicaid, there are many other state-level policy considerations. For example, I think Amy mentioned earlier that some states have deliberated policy around 988 telecommunication fees, and many other states could be doing that, and other dedicated funding streams for crisis services coming from the state level. Another unanswered question that we're really interested in right now is whether civilian response teams, or what types of response teams, should rightly have first responder status designation that's enjoyed by law enforcement and fire EMS. It's a workforce-related question that's really ripe for policy deliberation at the state level. And Jane, you also mentioned philanthropy. I do think that philanthropy can play a pivotal role as well, for example, by supporting policy research that answers the questions that lawmakers need to know. Our team is really grateful. It was mentioned earlier that our work has been supported by NAMI, as supported by Shannon Scully. Also, our work is supported by the Pew Charitable Trust, and Connie Utada, and also we're very grateful to the Sozosei Foundation and Melissa Beck, which have allowed us to establish the Sozose Lab, which is focusing on advancing research to end the criminalization of mental illness. A lot of our research has been quantitative and qualitative, but now we have a number of policy research questions that really need to be pursued as well.
Really helpful. Did anyone else want to add onto this one before we shift out of policy?
Yeah, I just
Yeah,
wanted
great.
to jump in because Michael had mentioned the state plan amendments and some of our other work. We've been looking deeply at what states are doing with these states plan amendments, and they're often adding new professions as billable professional services. So different role titles, which now can bill for crisis services. And so this is another opportunity to think about, the way the credential could be sustained is by doing a state plan amendment that would specifically add someone with this type of credential as a billable Medicaid service, since that really is the way many communities are trying to go.
Yeah, and I agree. Thanks to all of your work on leading the way on those policy questions and research. And we'll be sure to share information in the follow-up email about how people can learn more about the work you guys are doing. So we've talked about federal policy at all levels, but I think we can all agree that this work really begins locally. And I admit I immediately volunteered to moderate this webinar because of the work the Lee Foundation is doing here in Buffalo and Western New York. A year or two ago, we helped launch the Crisis to Care Collaborative, which is a countywide initiative, and we brought together about 35 stakeholders representing government, health and mental health providers, law enforcement, advocates, and of course, people with lived experience of the system. And what unites us all is our shared goal that people who are experiencing a mental health crisis should be matched with the right level of care that will help them get to recovery. And one of the resources you'll be receiving is actually some data analysis that we did from 10 of our partners of the work. And we really approached the data from the Samhsa model of someone to call, someone to respond, and somewhere to go. So we're really proud of the cross-sector work we're doing here in Western New York. But one thing I can tell you is it is hard. It does not come easily to have these different sectors working together. And it requires a lot of trust and persistence. So this question is open to all the panelists, but for those communities that aren't quite sure how to get started, what actions can they take at the local level to start strengthening the crisis workforce?
I'll start here. I think at the local level, really looking at what resources are in the community in terms of do you have local universities, local community colleges that could start working on what different types of skill-based training that agencies can work with these universities or community colleges to build something to help to skill up their staff. Also looking at working at probably at the state level too, in terms of thinking about how something could be built that, because I think part of it is, particularly for mobile crisis teams, is a lot of the funding comes through the state level. So thinking about how communities can work with their state behavioral health authority and Medicaid authorities to move some things forward so that they are able to pay perhaps a different set of folks doing this work, and then working at the local level too to make sure that there's training available for people.
And I would just add that I really believe in local crisis collaboratives. Jane, like the one that you described in Buffalo, I think that there's a lot of work that can be accomplished when multiple diverse stakeholders are around the table together with a common goal. It also sort of reminds me of stepping up initiatives in so many counties across the country that really have brought people together with a unified goal of reducing the number of people with serious mental illnesses in county jails.
And just to add on to what Michael said in terms of those collaboratives, I think getting people around a table from these different sectors and really explaining what this role and the training looks like, the values and competencies and skills, as we envision it, it helps people get more comfortable with who are these new provider types in the community. What are they, who are they serving? Who are they capable of serving? And what does that mean for your own system, whether you're a hospital or a law enforcement agency, in terms of your own workforce and the demands on your workforce?
So one follow-up question so we're talking about who should be in the conversation, like who do communities forget to include sometimes? Like who is the one that we're like, we forgot to invite or bring along? Like, is there any one group that you see we need to really make a point of bringing to that table and having that conversation?
I would start with, one of the things that we are trying to be intentional about in our work is bringing in people with lived experience from the beginning, whether that is through a formal organization, or through more informal community, collaboratives. And so I think really ensuring that that voice is at the table from the beginning as you're planning crisis response systems is integral, in addition to sort of the more traditional providers that I think people are less likely to forget about, like hospitals or law enforcement.
They're usually the first ones at the table, right, Leah?
Yeah,
They
exactly.
bring everyone else along. Great. And, I just reflecting on the work here, people often ask, like, how is it working with law enforcement or these other sort of sectors that maybe behavioral health doesn't always think of as a partner? And I find they're very engaged, and that they're seeing firsthand a lot of times where the system is failing. And so, although the language that we all speak might be different in how we think about it, they share the same goal. At least that's what the experience that we've had here in Western New York. But we're going to transition to safety. And Amy, I'm going to start with you on this, but one of the things that we often hear about is the safety of clinicians or peers or whoever is the non-police responder. And also the safety of the person who's having the crisis or experiencing the crisis. So how should we start thinking about safety? Like what do you
I
have
think
to share? What research can you share with us on the reality of those concerns?
absolutely. And I mean, I think part of it is one, recognizing that there could be some safety concerns, but they're also manageable. And really thinking through, there's some great examples across the country, particularly with some of the alternative response teams, going to 911 calls. I've not heard of any major injuries. I haven't, several teams have put out their evaluation reports. But really, one, historically, in many places, mobile crisis response hasn't been a team, it's been one person. So, really shifting to thinking about sending two people, and having some initial kind of assessment of what's appropriate for sending the team and what might be indicate that there's a need for a little bit more deeper assessment if it's safe to go to a particular place, or if there's a need to be able to collaborate with law enforcement, either as having them arrive together or ideally if just asking them to stage nearby if there's a significant safety risk. But when we talk to folks that were doing crisis work in the community, they shared with us that they have a number of different type strategies to manage safety that work quite well. Some of it is if it's possible, to gathering some information en route to a particular site. Having those conversations if you're going to somebody's home. Are there weapons in the home? Are they secured? Those types of things. And making sure that responder staff is trained in doing that so it becomes just part of their protocol. The other thing is having some training, which you don't necessarily get in social work school, and just assessing safety once you get there and the things that you need to watch for, the plans that you need to have in place if you need to leave quickly. But we can train people and support those in those skills. The other thing that really came through in our key informant interviews and focus group is something that's really important to safety is the ability to go and help someone downregulate and de-escalate, and giving them space. And so there's very specific de-escalation skills that we can make sure that our teams are trained in, so that they're showing up and really helping the person feel like they're not under threat. because I think that's where things get unsafe, is if someone's feeling very vulnerable and then somebody comes in that represents a threat.
Yeah.
So I think there's a lot of different there's some skills we can train our mobile crisis teams in. There's some team operational practices to put in place. And then also really working with if being able to collaborate with law enforcement when it's needed. And I know I saw a question here too in the Q&A just about helping teams, making sure teams recognize sort of the experiences of marginalized communities and not over relying on law enforcement. And I think that can be a really important part of the training and supervision of these teams. But also, if we're expanding our workforce and diversifying our workforce, we may be able to hire people that actually are more familiar with the communities that they're responding to. They're better able to move within those communities and also better able to judge what might be uncomfortable versus what's actually dangerous. So I think that's another thing too, is if we expand who we're bringing to this workforce.
Yeah, all good points. Really appreciate the thoughtfulness of that answer. Because I know we want to get to Q&A. We are going to a couple more questions for all of you, and then we can shift to that. But these are just broader questions, and I'm going to let you guys decide who's going to jump in and take it or not. But sort of building on what you just said, Amy, how do we recruit and support a more diverse workforce? We've talked about removing some financial barriers, but are there things you've seen work well in communities or groups that are doing a great job at sort of identifying these folks?
Maybe say a little bit about the community college environment. And, I listed out a couple states where there have been, I think, maybe some more successful and enduring apprenticeship programs for behavioral health roles across community colleges, and maybe some others that have been a bit more short-lived. So I do think there's like a glaring research question for me I would like to understand, like, why are some of these programs successful and why are some of them not lasting for beyond their pilot phase. And a question I'm wondering is, how do those programs engage stakeholders, community members, people with lived experience, both from the beginning and in an ongoing way, to co-produce these models, these programs, and really think about what's going to bring in a broader group of people for whom paid work-based learning is really going to allow them to enter the field without massive debt or some other burden or opportunity cost that is just going to lead to quick burnout or turnover.
Have you guys seen anyone doing work at the high school level? So we talked about that you don't need a college degree. Like, is there any sort of push into high schools to sort of introduce this career path or not yet?
Oh, go ahead, Leah. Did you
I
want to
was
take
going to
that?
say I haven't seen that yet, but that would be really exciting. I know that there are initiatives to train younger people on mental health first aid, for example. So there's definitely some movement around more education awareness for teenagers, but no, I haven't seen anything specifically.
I've seen people talk about it. I've also seen some, particularly in the alternative response programs, some of them have produced videos talking about what the role is. So I do think as it becomes recognized more in media, social media, it'll actually be an idea that people have. I have also talked just anecdotally to some folks running alternative response teams, and when they got first responder status, which I think there's a need to fully explore what all that could mean, but it actually recruiting became easier, and they got more men and more people of color applying for the role. So I think some of it is how we describe the workforce, because unfortunately we don't pay or give much prestige to people working in community and mental health, and I think that needs to change.
Yeah.
But with that, I think sometimes calling it a first responder type of role will attract a broader group of people that might be interested in it.
Yeah, that's a great idea. I am gonna, so we're gonna, because I want to make sure we get to everyone's audiences, I'm gonna turn it over to Allie, who's been, I'm sure, behind the scenes working her magic and collecting these questions. So Allie, I'll pass it off to you.
Yeah, so the first question I will jump into is from Michelle. She asks, how are negative effects of standardized credentialing being considered and addressed, especially for marginalized workers? Many who are doing grassroots, hyper-local alternative community support. It seems the problem we're solving for is how current required credentialing is strangling the workforce. How will this new, although lowered, credential not create the same issue?
That is a really important question. And I think it's something that we've struggled with as we've been doing this work, as we don't want to create a barrier for people to enter the workforce, but we do want to create pathways for people. Um, so I think it's it's a point that's been on our mind as we move forward in this work. I don't know that I have a specific answer on the best way to prevent that other than trying to continue to be aware of that. Because I do worry that sometimes what we see is I've seen some alternative response programs in particular that are so innovative and doing such wonderful work, and you don't want to wreck it by standardizing it. Um, so figuring out how to come with that balance to make it sustainable, which that's the hard part with some of the grassroots stuff, is staying sustainable without losing what's special about what they're doing. So again, I think I don't have a great answer other than it's something that we've really thought about and we're trying to continue to be aware of.
Great, thank you. So another question was, how can people that aren't leadership within their organizations but work on mobile crisis teams or co-response teams or supervise those um, promote change within their agency? So I think any tidbits or personal stories would be great here to help kind of address this question.
I have one thought. Oh, Leah, do you want to?
No, go ahead. Go ahead, and then I'll go.
Um, one one is bringing resources to the organization. So even if you get the recording of this webinar, sharing it with leadership, looking for other resources. There's organizations that you can join. Um, uh, AMSA is one organization that is trying to bring together people working with in alternative response and mobile crisis and provide resources. They have you get a newsletter every week and they highlight new articles and stuff. So it's another way of providing material that someone working at an agency can pull some things together and continue to have those discussions with leadership, but also stay connected to sort of the larger work going on at the national level.
Yeah, I think that's a great ideas. And I was just going to add to what Amy said by in the Think Bigger, Do Good paper, we link to our paper that has the values and competencies that's accessible to anyone. And just even sharing that with your organization and thinking about it as a tool to take stock of, what is our organization? What are our values? How do they match up with these? Similarly, what competencies and skills do we train in? I think it's a really great opportunity to have productive conversations around sort of what the values are that drive the work of any particular agency, and then potentially even trying to advocate for bringing in some of these values that maybe aren't represented in your agency right now, and asking what would it take to make autonomy, for example, something that's more present in our work.
Great. Any other thoughts on that question? All right, so I'm going to try to combine a few, and this is really to the credentialing. So, a couple more, I think, practical implementation questions came in. So, will there be a clear scope of practice for the credentialing, and will it be offered in virtual format? If so, synchronous, asynchronous. I think people are trying to figure out like how can they access it already and plan ahead. And I think some questions that had been answered too were Amy said 10 to 12 months before it could be ready and employment can vary, but more details are desired on the credentialing.
Sure. So we're researchers. Um, and so we connected with the Illinois Certification Board because they know how to stand up a credential. That's not something that we've done before. And they are working on it. I think I would actually, and they will probably put in a standard about how much of the tr training could be virtual versus in person. I personally think that there should be a requirement that some of it be in person so people can practice skills because the work they're going to be doing is in person. And I think skill practice has to be a really important component of the training. But ICB will be moving that forward and thinking about the scope of work, which I think will be important, as well as kind of the different options of pursuing the credential. But that's something that that is why we partnered with an organization that develops credentials, because that's not something that's been in our wheelhouse. So we've been really happy to be able to connect with them and learn along the way too about how that's done.
Great. So I will say in the Q&A, we've had some great suggestions that were not questions. So thank you to folks that have provided specific examples or places to look. But I think we'll begin to wrap it up. And Jane, if you have any last questions as moderator, you have the floor
Yeah, if I
for
can
two
like,
more
I
minutes.
was gonna say go a minute over. So I want to make sure that, our audience leaves with some real tangible takeaways. So, we'll maybe start with Michael on this and then pass it around. But can you offer a suggestion of what our participants can do in the next year to start building a stronger behavioral health workforce? So given all that we learned, where should they start and what's feasible in the next 12 months?
Well, I don't know if this is a great answer, but it's something that has occurred to me as I've been listening. And that is, I think we've been focusing a lot on crisis response out in the community, but I would really encourage all of us to think about the full crisis continuum with regard to workforce. We need to think about 988 call takers. We need to think about, yes, mobile response out in the community, but also our crisis stabilization and receiving facilities, crisis respite, a really important part of the continuum, crisis residential services, and even crisis transportation. What does our workforce need to look like with regard to crisis transportation if we want to pull that function away from local sheriff's offices? So I guess I don't have a great answer other than let's think about the full continuum of crisis services as we think about the workforce.
That's a great reminder. I think the workforce shortage crosses that whole continuum. And I certainly know our 988 and hotlines are trying to figure out how to keep them fully staffed. So thanks for that. Anyone else in the group who wants a clear takeaway, an actionable item?
I would say that it's helpful for programs to continue to learn from other programs in terms of what creative solutions they've come up with for staffing and what are the various roles that they're using to staff their teams currently. We just completed a national survey of mobile crisis programs, and we should have a lot of data to share from that this summer. And one of the things we asked about was the types of roles and how many FTEs, fill those different roles on the teams. And I think that we're excited to be able to share just the large diversity of roles that are really out there in the field. And I think just learning about sort of how different paraprofessionals are being used to fill some of these gaps is useful and may give programs creative ideas to fill the workforce needs.
Yeah. Kellan, having worked in the field, any last thoughts for our group on where they could get started?
Mhm. Well, maybe it's a bit of like having been in the position of hiring people when I was on a crisis team. Yeah, we really need to get away from this sort of desperate hiring situation where people making employment decisions are just looking for a pulse to fill a role, and think about who really wants to, hopefully, like to move to a world where we've got people who want to do this kind of work, have been trained to do it, and are interested and supported to make careers in this work, rather than sort of quickly sort of burning through crisis work on their way to some other position in the field.
Yeah. Amy, we'll end with you. Any
Sure.
final thoughts?
I would say make sure that you're talking to the stakeholders in your community, particularly people who may use your crisis services, and make sure that they have a meaningful input in the work that you do to build your program.
Yeah. So thank you to everyone who's here and to all our panelists. Thank you to Allie for working behind the scenes so seamlessly. During our conversation, we did mention a lot of resources that we will be sending off to you. So don't worry if you didn't write it down quick enough. And we hope you'll stay connected with Think Bigger, Do Good. You can follow us. Allie's put up some wonderful QR codes, but you can always just go online and find us. But really just grateful for the conversation. My thanks again to the panelists, and I hope everyone has a wonderful afternoon.